History program for Professor Jason Ruiz's Latinos in Chicagoland and Northern Indiana class at the University of Notre Dame. Today's date is April 8th, 2010. We are at 307 North Michigan Avenue in South Bend, Indiana. The interviewer will be Emily Forster, student in the class. I will be interviewing Leonara Battani, Manager of Language Services and Latino Outreach. Thank you, Leonara, for participating in our oral history project. Would you please state your full name, date, and place of birth?
My full name is Leonora Beatriz Oates de Battani. My date of birth is January 5th, and I was born in Buenos Aires, Argentina.
To begin, I would like you to tell me about yourself, your background.
Well, I was born in Argentina. I immigrated to the United States in 1977 because of political problems in Argentina. Having had married in Argentina to an American citizen, things were very sketchy for American citizens in Argentina in the 70s. A lot of them killed and kidnapped, so we decided to come here with his family was and bring our children here. So I left there my career. I had studied medicine in Argentina. So I came in 77 with no English and no family.
How long did you study medicine? Did you practice medicine in Argentina?
No, I never did.
Okay.
I finished, but I never did practice. We came here.
So you had children in Argentina?
Yes.
How many?
2 there, 1 here.
So are you a citizen now, or are they your children citizens?
They are citizens, and I am a citizen now. Of course, the young one was born here, so yes. I became a citizen not too long ago, 2001, I think.
And so you had education in Argentina?
Yes, and here too, I went to Bethel College to do social services. And at ENT as well. That was my first study, and here in the United States I wanted to know if I knew enough English that I could handle going to school. Wasn't that pretty, but I did.
So how did you learn English?
With the kids. Having to read to them in English so they could do better in school, and so we all learned together, the kids and I. Of course, they still make fun of me. So.
Do you speak English with them at home?
I try to speak Spanish with them at home, but of course they're adults now. But yeah.
Can you describe your position here as the manager of language services?
My position started as a coordinator position, and Hispanic Initiative was the title. And basically, the hospital gave me carte blanche to do whatever needed to be done to serve Latinos at Memorial Hospital. So what I did first was an assessment on the needs of Latinos at the hospital. So we started with language services, looking for ways to serve in, Latinos in their own language. There is also provision of Title VI, which is the law from the Department of Health and Human Services that said that patients need to be treated in their own language. So with that, I started looking into how to train interpreters. So we hire a few contracts to see how we could do all that, and then of course now we have 24/7 in the hospital. We also decided after a while that we needed to look at, we had a lot of births, a lot of mommies coming in, to be a dual role instead of just being a medical interpreter, to do something else. So we train people to be doulas, which is a profession that is a labor coach. So we have doulas 24/7, which have the dual role of being doulas and medical interpreters, and then the interpreters.
And just to go back on your background, did you first come to South Bend after
Yeah,
immigrating?
I never been in any other place. South Bend.
Do you know why you chose South Bend?
Because my in-laws were here.
Oh, okay.
They were in Mishawaka, but
Okay.
we stayed in South Bend, and they went from Argentina to Monterrey, Mexico, Ireland, and then the United States again. And I mean, my father-in-law was originally from Detroit, born in Detroit of Italian parents, and my mother-in-law was from Milan, immigrated when she was 9 years old.
So what is a typical workday for you like?
Typical work day, we have two programs, the Latino Outreach here at the NIPSCO building. We started a program for diabetics, Latinos with diabetes, because they were the population that was underserved. Nobody took care of them, and they didn't know much about diabetes. And soon to realize, once we started teaching them out there in clinics, that they needed a lot more. They needed more case management, following up with them. So we, little by little, started a program of classes on case management, and we gave them the glucometer, and we work with their glucose readings and the physicians. We started in 2003 with a handful, and now we have over 200. But we have incorporated English classes for the Mexican Americans, and then the doctors now send us all races. So the typical day, I will start here sometimes, work with the staff here. I mean, this is a share office, so community health enhancement, which is the umbrella in which our programs are. And I can start in the hospital with interpreters and doulas. Depends what my day is. And we also teach a medical interpreters class, so I can be preparing for that class to give at night. So
kind of talking about the diabetes, is that a particular health concern for Latinos?
absolutely, that is one of the biggest. Heart disease and diabetes are the biggest killers of Latinos, and it has become a pandemic in the world. But we seem to have a lot of Latinos that is genetic, because everybody in the family has it. Now, because our people are always think that it's God's will to have diseases, so a lot of times they don't get treated, because they said, if God gave it to me, then I'll have to live with it. Our teaching is that's okay, if you think God gave it to you, but God doesn't want you dead, so let's work with that and help you live a healthy life. So we have had very good results. All our programs have an outcome. They're outcome based. They're not number based. We don't care how many people come, but if we are making a difference. And one of the things that we do is measure the A1C, which is the glucose levels in the cells for 3 months. A normal one is 6.5, 6.8. And when they come to us, usually their A1Cs are 13 or 12. So probably from 6 to 8 months, we are able to work with them to lower their A1Cs at least 5 points. And then in a year, have it in a normal range. So that's one. Our biggest outcome would be self-management. If they can test their sugars, they know how they feel, they know if they have eaten something wrong and their sugars are high. And so our ADA, the American Diabetes Association, says that if somebody can manage their disease by themselves, then they haven't made it. That's what we strive for, is self-management. But we're dealing with a population that is uninsured, so has no money for medication, of course none for for glucometer and test strips. The test strips are $1 a piece. And then little by little we incorporated gestational diabetics, women that become diabetics during pregnancy. And that is a little bit more of a crisis because it's a very short time. Glucose test is not done on the mothers until they're 28 to 30 weeks, and sometimes a little bit after that. So we have a window of 8 weeks, 10 weeks to work with them to make sure their sugars are controlled, their weight is controlled, so the baby can be healthy at birth. We have been very successful at that. We also look for outcomes, and the outcomes is that the mother's healthy, of course, that the baby doesn't weigh more than 10 pounds, and that the baby doesn't have any of those side effects of withdrawal from high glucose in their body. They can't control the glucose once they're born, so if we can take care of the mom, then those things won't happen to the baby. So we have been able to do that. We have never had a baby in more than 10 pounds since we started the program with the moms. But of course the moms have to do the job. We can't do it for them. We can harass them to try to make them, but we always say that we harass them to compliance, but sometimes once they see that we care, then they may care. So.
Do you know of any programs for preventing diabetes?
No, there isn't many. We invite the families to come. We invite the children of the diabetics, and we talk to the young kids and young adults as well. And we treat the whole family, because they have to change the way they live completely. So we have been working on that, but there isn't a prevention type of, because the needs of the chronic disease are so big that nobody has the funds to work on those prevention programs.
And so you work with, is it mostly Mexican Americans?
Yes, mostly Mexicans. Very few Puerto Ricans, just a handful probably, and that's it. I mean, in this area, the majority are Mexicans, but we have few pockets of Puerto Ricans and Hondurans. We basically work with Mexicans here in the diabetes program. In the hospital, no, we see a little bit of every country that comes in. More so with Notre Dame, because we have sometimes take care of spouses of students, doing PhD work or something like that don't speak very well English. So when they show up in the hospital, we always said that, when you hurt, you only speak one language, and that's your native language. So, you forget totally your second language. So that's...
So you kind of spoke about how people are sick. They say, you've heard this is God's will for me to be sick. Is there any other ways that you think religion might make people think differently about healthcare or their own health?
Well, it depends. It depends on the Latino and the Latino culture. But Mexicans are what is called fatalismo. They always think the worst out of things. So, which doesn't happen with other ones. With other parts of Latin America, they're not so fatalistic about things. But yeah, I think in that sense, religion has a lot to do. But we have seen a trend, a shift in religion from Catholic to Jehovah's Witnesses of our community too. So we're dealing with a totally different now, a subculture of Mexicans.
So are most of your clients are Latino?
Yes.
Have you ever faced any criticism that there is a Latino outreach and it's kind of specifically?
Absolutely. In the hospital we have that with the doulas. When we started the project of the doulas, there was a lot of criticism that that we were going to only offer those services or labor coaches to Latinas and nobody else. Yes, absolutely. And it took quite a while for them to stop. And that was staff. I'm not talking about outside people. It was staff saying that. And the only way that they stopped is that they saw that the doulas were willing to do anything for anybody, and the service to the Latinas was so great. Then people stopped. But there's always criticism when things are new, and then when it talks about money. When there is money involved, then there's always, everybody wants a piece of their own pie, and when you're having to cut that pie into another slice is not good. People get upset. So just have to live with that until it calms down, I guess.
Speaking of money, where do you get funding?
Well, we started with funding from the hospital, and then we have a foundation. We have a memorial foundation that give us money to start this program. We got a few grants to work with the gestational diabetics from March of Dimes, but of course they run out, and you can't apply year after year. So one of the things that we had to do is start looking into making money, and one of the things that we do is we have a business which is language resource services, and so we sell interpreter services outside the hospital to doctors' offices and physicians and surgical centers, and so we're interpreters for hire, and we make money with that to fund the diabetes program. The hospital, the doulas and interpreters are totally funded by the hospital.
This is kind of general, but like if you could kind of guess what percentage of Latinos in South Bend have health insurance?
4% probably. And okay, let me qualify that. If they're pregnant, they can get at least emergency Medicaid. Emergency Medicaid means that they're only going to cover the birth of the child, but they're not going to cover the OB visits. That's why we have several clinics that take care of them that will give them a small fee per visit to pay. So really the birth turns out to be really cheap. Elkhart County, for example, no doctor will see people with emergency Medicaid, so they all come here. So we have double the burden of pregnant moms with emergency Medicaid. There is another program now. It's called Healthy Indiana People, and if our Latinos have papers, if they are residents, legal residents or U.S. citizens, then we can apply for that for them. Not many qualify, unluckily. Some of them are offering insurance at work, but they can't afford it. I mean, it's too expensive. So, and we have a couple of elderly on Medicare, so which they have to be U.S. citizens for that. So, but most of the people that we see here in the diabetes program are undocumented. So.
Maybe describe the different experience of having a baby in the United States if you're documented versus if you're
that it really is. There is no different. I mean, because they get coverage, and then the clinics take those moms. We have 6 clinics that anyone can go. The only way they ask for papers is just to make sure that they don't qualify for something else. But nobody asks about their legal status to do harm or to send the INS or anything like that. So in the hospitals, not just ours, I mean, people are treated well, and in our hospital, I made sure that nobody asks, and nobody needs to know that what the status of a person is. To take care of them, they don't need to know that. Now, if there is a case, and what, not for moms, but if we would have to do a transfer to a extended care facility of an elderly person or somebody that's hurt, then we need their status, because otherwise extended care facilities will not take care of an undocumented person because there's no insurance. That's when the big problem comes. That is absolutely a nightmare, and there is no out. Either the family takes care of them, or that is one of the problems. And if you look into, there's been a lot of research, and a lot of criticism about the healthcare in the United States. What do you do with an undocumented person that has a length of stay in a hospital? And the hospitals are not rehab hospitals. They're just that, to take care of the problem and then move on. And so there's been a lot of work and a lot of criticism and a lot of painstaking trying to find out what to do in a case like that, and nobody's found a solution. And it's horrible, it's terrible, but
How do you feel about the current healthcare situation? How do you think the changes being made are going to affect your clients?
Well, I'm not sure exactly, but I saw one of the provisions said, and I was very happy to see that, it said U.S. citizens, U.S. residents, or people that reside in the United States. So that makes me think that undocumented are going to be covered with insurance, whatever that insurance will be. So I was really happy to see that. So I'm not sure. I'm not sure what everything else is going to come our way. But
if you could change one piece of legislation,
that will be it.
That'd be it?
That will be it. Make sure that, and it's not that we don't take care of them. And like I said, both hospitals here in the area take care of undocumented with no problem. Not again, people tend to tell us, not other people in the hospital, but it is the burden of that is the extended care of somebody needs something more after the hospital. I mean, we had, for example, a fellow that was in a car accident, and he was without 8 months until we were able to find a solution for him to get rehabilitation in a house, in his home. And that's, nobody should be in a hospital for 8 months to start with. I mean, we're not equipped to have, long-time residents there, and it was painful to see, that poor patient there, but we can't let them go anyway, if they don't have any place to go. So.
Are most of your our clients undocumented?
Probably. I don't talk about it much because of all the anti-immigrant situations. We have stopped talking much about it. Before we used to, and there was always help with that, but that stopped when everybody started talking bad about immigrants. So we stopped talking about it too.
How would you describe your typical client?
Poor, undocumented, illiterate. That's another thing. We have probably 50% of our population is illiterate in any language. And the shift in culture, I have worked with this community, with the Mexicans for 30 years, but the culture has changed. The family units are not as tight as they used to. I think they have a culture related, but in a wrong way here. Kind of kids go one way, the parents go another way, and then you have elderlies that need the care, and it isn't the same that it was. That the elder's daughter took care of the parents until they died, and that was her job, and you don't see that anymore. So that's been kind of a shock, cultural shock for me to see from years past. But yeah, I think that would be my clients.
How do you think your clients are perceived by the non-Latino society?
Terrible. Nobody wants them. We always say that they're the throwaway society. Even I have seen Mexican Americans mistreat them and not treating them with respect just because they can't speak English, or they can't speak English well, or they perceive that they're undocumented. They don't know, but they are willing to bet that if you don't speak English, then you don't have documents too, which of course is not true. But so yeah, I mean, it's kind of hard.
How do you feel about bilingual education?
In the total sense of bilingual education, I worked for bilingual education for 18 years, but we didn't do bilingual education. We reinforce English. But I know in California they have bilingual education, and I'm not sure if I agree with that. We are in this country, and we do have to learn the language. It's beautiful that we can keep our languages, but we need to learn this one too.
So you train interpreters, but do you think it is good for doctors and nurses themselves to be bilingual?
Well, that would be fantastic, but it doesn't happen in the Midwest. First of all, when we do have a true bilingual doctor, or a doctor that is a native Latin American, they leave. They go to warmer weather, and where they pay better. For some reason, apparently we don't pay that good around here. But so we have lost quite a few of wonderful doctors we had, specialists. But one of the things that we have a National Council for Interpreters, and one of the things that we're always scared is that physicians are using the limited language, whatever the second language is, to communicate with patients, and then the patients are the ones suffering because they're not understanding everything. And it's very difficult for us, for example, interpreters, to tell a doctor, please use us instead of using your whatever language it is. But we're not very successful with that. But yeah, it would be fantastic. We do train bilingual nurses to be interpreters. That's a dual role. That's not, it's a totally different thing. But we don't have many. We don't have, and that's one of the things that we're encouraging. Here at Washington High School, they have a health career. It's a magnet school for health career. So we are capturing the kids in 10th grade, working with them to make sure that someday they graduate and they go into any medical field. Hopefully we get more Latinas and Latinos in medical field, and that they stay here with us.
Even if a doctor, a non-Latino doctor, spoke perfect Spanish, do you think there's anything that kind of wouldn't be able to, kind of like a cultural interpretation that might need to happen?
Well, yeah, I mean, cultural is a big part, and we have that with interpreters. Sometimes they're very good, they're very bilingual, but they don't have the cultural nuances, and that's one of the things that we train in the interpreters course, is some of those, not only language nuances from one country to the other, one region to the other one, but to be very careful with that. So yes, we have a few doctors that speak Spanish, but they learn in another country. They were there, during college or doing religious ministries, or so. But we keep an eye on them just in case. But
what do you think is the greatest health issue facing Latinos in South Bend?
Well, cancer is one. Diabetes and high blood pressure, of course. Those are the three biggest we have. nationwide, I think cancer is the biggest, but we haven't seen that. I think that is kind of teetering side by side with diabetes. And of course, high blood pressure goes with everything, so it seems like heart disease. As we see our folks getting older, because 20 years ago, we only had our Latino population here, the median age was 20. The elderly went back home or to Texas, wherever, it was warmer, or back to Mexico or wherever they came from. But now they're staying, so we're starting to see an aging population in a community. So, we're starting to see a lot more chronic disease and Alzheimer's. There's a big push now. They have found that we are just heading for the highest incidence of Alzheimer's. And we wonder why. So we have a BrainWorks in our hospital. And so we're going to start working with them to see what we can do about preventing Alzheimer's and doing some things with our Spanish speaking so we don't have that. So.
How about like health concerns of children?
Obesity. Our kids are fat, really fat. And that's a cultural thing too, because the babies cry and mothers feed. But we found the babies cry, mothers feed, but they don't talk to them. So two things that we started. When we started a program in Bilingual Education summer school to work with the pre-kindergartens doing nutrition and exercise classes. So we did it last summer school, and we hope to do that, trying to work with those kids. So if we start with a mindset that early, maybe we can make a difference. We also work with the gestational diabetics to work on that, so they are more aware of how the nutrition needs of their babies. We work in two programs. We do a Shake and Baby program, which is, we had quite a few incidents of death of kids being shaken by a family member. And then we do something that's called Talk to Your Baby. And basically it's a hands-on, very simple curriculum that we even for illiterate moms, that they can talk to the kids, they can read to the kids just with pictures and invent a story, but that they need to be expanding their brain. And so we're working in those little simple programs, but starting to create awareness that a child needs a lot more than just being fed all the time or being held, but without talking. So, of course, our circle of influence is not the whole total population, but little by little.
How do you think gender plays a role in healthcare? Like, do the men and women do you see any differences in how they approach
absolutely.
it?
Men don't go to the doctor. But saying that, I'm going to contradict myself. Most of the clients we have in diabetes programs are men. So it is amazing. I never dawned on us, to count, through gender how many we had, but our classes are most attended by men. Of course, the families come with them, the wives and all that, but we're counting who is our client. A lot of men, a lot of single men as well. We have the diabetics are younger and younger, and that's from childhood obesity too. So we have quite a few 20-year-olds, from 20 to 30-year-olds. Big chunk of our clients are in that age group, so it's pretty bad.
What do you think is the most difficult part of your job?
Politics. It's not working with the clients. That's my passion. I'm easy with that. Is the politics of trying to bring up on the awareness that all populations need care, and that if we don't take care of this population here, then 10 years from now we're going to have a lot more problems. I'm going to spend more money. So the politics of, I have to show them how spending some money here, we will save money in the long run and in the short run too. I mean, because we reduce hospitalizations, we reduce the different things that can happen to a diabetic. So, and in the hospital, of course, with the interpreters being there, we reduce the amount of time that they spend with the patient and the amount of tests that they do when they can't tell you what's hurting, and then they have to do all this kind of tests. So, but I have to show dollar and cents as well as the part that is the right thing to do. So.
So are the interpreters like on hand all the time in the
Yes,
hospital?
24/7. Mm-hmm.
So no one will ever come in and not be able to.
We take care of all patients of all languages. Mm-hmm. Anyone that is limited English proficient. I had asked a few years ago to, when the patient comes in, when they're doing the registration, they will ask what their primary language is and what is the most comfortable language that they speak. We have signs everywhere in the hospital and in the points of entry that they can point to a language, so we know what they need. And of course we have Spanish face-to-face. We have one French interpreter for the Africans because we're seeing quite a bit of that population coming about. And then we have a telephonic interpretation service that we can serve 140 languages. And then we have a video interpreter services for sign language 24/7. And that is a lot of money. So when you talk in politics, those are the things that, yes, we're serving the people, but nobody pays for those services. I mean, all those services are free to the patient. No insurance will pay for that. So, there's the politics, it's like we can't afford it, and a lot of places can't.
How long has that all been the way it is? Like
8 years, 8.5 years.
Before then, were there Spanish interpreters, or?
Before that, there was one that did dual roles, and then, of course, the telephone. The telephone company had been installed quite a few years before, like 15 years ago. Not that everybody used it, so now we insist and we encourage staff to use the telephone interpretation services. A lot of times, people that speak other languages, because of their limited English, they don't tell you that they need something. So they'll shake their heads, or they smile, and so staff feels that they are understood, which they're not. So that is another set of education that we have done for many years, not to assume that the patient is understanding you. Assume the patient is not understanding you. Use that phone, and, if they are understanding you, then it's fine. But make sure they use the phone first to assure that they're okay in English. So that is a totally switch in mindsets, and it's taken a long time, long time.
Where do you see the future of your position in the next 5 to 10 years? How do you think it will change?
Well, everything changes. We're not seeing a growth in the population right now. A lot of people went back to Mexico when all this mess with economics started. The growth that is happening is births, not families coming to this area, which before they calculated. Somebody did a small study in Laporte County. Per week, there was 100 families coming in to Laporte County, which is a lot smaller than St. Joe County. So that has kind of stopped. So we're seeing the growth in birth, but not as many families coming. So I think it's going to get more intense because we grow older. So the worse, the health is, then more work we have. But I don't know if this law is going to change it to help us or not, but we'll see with that what happens.
What is the most rewarding aspect of your job?
Everything, every day, serving the underserved. Every day is a wonderful day. Not today so much, but today we have one of those throwaway patients that nobody wants. So today is a sad day.
Yeah.
So.
Well, what else would you like people to know about your job that we haven't covered
Well,
in this interview?
my jobs in the United States has always been to help. I started working with migrant farm workers. Never had, I come from Argentina City, so never seen that type of workers, and that was absolutely rewarding. And through the years, all my jobs have been with Latinos, so I feel very lucky that I've been able to serve people that I love to serve, part of my community. Not everybody has that choice.
Do you feel part of the Latino community here?
Absolutely. Even though I'm the waiter, like they call me, I'm the white girl amongst them. But yeah, I'm part of the Mexican culture, really, because there wasn't many Argentines, and there's still not many Argentines since I moved here. We didn't have any, and I think the first time I saw one is like 15 years into living here. So, and people that come to Notre Dame just for a while, but yeah.
Well, thank you so much.
Thank you.
So great to talk to you.